monoclonal immunoglobulin deposition diseases, MIDD. And a subset of this would be your light chain deposition disease, which is the more common variant of this monoclonal immune deposition disease. So with that reintroduction or that orientation, let's take on this topic. So you recall, I hope, that myeloma can cause kidney disease in a multiplicity of ways, one of which is amyloidosis, which we just talked about. Another is Cas nephropathy. But here is another one, that is the monoclonal immune deposition disease, as another pathway for kidney manifestation or monoclonal gammopathy of renal significance. So you can see that this MIDD occurs in the minority of myeloma patients. And a patient may not fit the criteria of myeloma by plasma cell clone proportions in the marrow, but once you have an organ dysfunction related to a plasma cell dyscrasia, it warrants treatment. So that categorization may not be so relevant. Can you please kill this? Now, this form of deposition disease certainly affects the kidney, but there are descriptions of deposition disease with disorganized deposits affecting other organ systems as well, including the heart. This is predominantly driven by kappa variants of myeloma, and contrast that with amyloidosis, as we discussed previously, which is primarily driven by a lambda clone. But this is not universal. So you can have both with either kappa or lambda. There is this, again, predilection, but it is not direct or complete. And let me remind you again that it is the property of the paraproteinemia which confirms the disease expression. Reflecting again on something that I said during our discussion on amyloidosis, if the light chain produced, or the intact immunoglobulin, or the heavy chain, all of those can be produced by the plasma cell clone. If that paraprotein has the property of misfolding into beta-pleated sheets, then you'll have amyloidosis. If it has other properties that result in filtration by the glomerulus and adherence to TAMS horseful protein, then you'll have Cas nephropathy. And then monoclonal immune deposition disease is yet one other manifestation that is confirmed by the property of the paraprotein. Renal pathology would be Congo red negative. Remember, that is a primary branch point in making the diagnosis of these deposition diseases. Is it Congo red positive with birefringence on polarized light? And if so, that would be strong argument that you're dealing with amyloidosis. These are Congo red negative. And the feature is of powdery deposits that you can see on electron microscopy and involving both glomerular and tubular basement membranes. I'll highlight the tubular basement membrane feature in particular. There's not many glomerular diseases that also result in tubular basement membrane deposits. When you see that, it really narrows down the differential diagnosis to really a few things, and monoclonal immune deposition disease is one of those things. You can see tubular basement membrane deposits uncommonly in lupus nephritis, but it's universal in monoclonal immune deposition diseases. And we saw these pictures in our previous discussion, this would be that powdery deposit that I describe, replacing the basement membrane in the glomerulus as well as the tubules. Okay. Now, the light microscopy would, in many cases, reveal nodular glomerular sclerosis. You recall, I hope, prior discussions about differential diagnoses with nodular glomerular sclerosis, some of which are strongly silver, most of which are strongly silver staining, the classic of which is diabetic nephropathy. This would be weakly staining nodular glomerular sclerosis. You certainly can see some endocapillary proliferation or mesangial proliferation with MIDD. And then again, we've talked about the EM deposits that you can see, but on PAS stain, you can also see some of these deposits that are PAS positive around tubular basement membranes and sometimes in vessel walls. Immunofluorescence is going to be strongly positive. It's going to be linear. As you think about linear staining on your glomerular basement membrane, anti-GBM disease is one of those, but certainly monoclonal immune deposition disease is another. Of course, in the one case, it will be monoclonal, right? It will have a predominance of kappa light chains or lambda light chains, distinguishing those two entities, GBM, anti-GBM disease, or MIDD. Okay. Treatment is generally going to be the typical treatments for myeloma. Often it involves a proteasome inhibitor, varying degrees of steroids. You can, as I mentioned, in the healthier patients, pursue autologous bone marrow transplants. It's rare that your BMT team is pursuing allogenic BMTs unless the patient has severe refractory disease and is still healthy enough to undergo that most extreme form of treatment for myeloma. So now let's go into the fibrillary GN, immunotactoid GN. So these would be examples of organized immune deposits because they have substructure, as we mentioned previously. I think I can sort of round this out pretty quickly because I believe we covered most of this in previous conversations. The deposits are really renal limited, unlike MIDD and amyloidosis, which can involve other organ systems. In fibrillary GN, we talked about this usefulness of this DNAG-B9 as a additional component of some of these deposits, as well as potentially being a diagnostic tool where you're staining or performing some other immunoperoxidase stain for this heat shock protein present on renal biopsy tissue. Fibrillary is the more common of the two, although both are quite rare. Most cases of fibrillary GN and immunotactoid GN are idiopathic. However, there are forms of secondary diseases. Fibrillary has an association with paraproteinemia, malignancy, autoimmunity, including lupus, inflammatory bowel disease, and thyroiditis. Immunotactoid is more commonly associated with these liquid tumors, CLL, lymphoma, and also a detectable paraprotein in the periphery. There are instances of immunotactoid being described in hepatitis C as well as lupus. Actually, we have an interesting patient with lupus who, on repeat biopsy, had lupus nephritis, but on repeat biopsy, the dominant feature is immunotactoid. There really is no evidence of lupus on follow-up kidney biopsy, which is a unique presentation. Just diagnosed within the last, I would say, 2 months. In my first case of SLE-associated immunotactoid. Renal path, again, Congo red negative, fibrils are present on EM or microtubular structures. We've already looked at that, so I won't belabor the point. And then light microscopy can also show nodular glomerular sclerosis. You can see fibrillary and immunotactoid are in the differential again for nodular glomerular sclerosis. And then you can have proliferative lesions as well, including crescentic GN and even membranous nephropathy. IF is positive in some of these in these areas of deposit, and again, there's less class restriction, and in these conditions, immunotactoid would be the one that once again is most commonly associated with paraproteinemia. Again, we've discussed DNAG B9 as a potential diagnostic test for fibrillary GN. And there is really no good evidence-based guidelines for treating these very rare conditions because you can't practically complete randomized controlled trials in this disease space.